press admit.
Okay, welcome everyone. We're going to make a start. So welcome to the webinar today, which is about innovative trial designs for rare diseases. My name's James Wason. I'm a professor of biostatistics at Newcastle University. We also have Tori Homer. Someone was making background noise there. We also have Tori Homer from Birmingham, and Amber is a project manager in Newcastle who's organised this today, so thanks, Amber. So we are recording this. We're going to stop the recording once the talks are finished, and then we move on to the Q&A. So we won't be recording the Q&A. If you don't wish to appear in the recording, then please keep your camera off and don't say anything. So just to give you an overview of the webinar, I'll be starting, and this webinar today is in association with two different rare disease initiatives. One's called the Acceleration of Rare Disease Trials, or ARDT, and the other one is the Captivate node. And I'll be talking about what ARDT is, and then about 20 minutes on an overview of innovative trial designs for rare disease trials. And then Tori will be talking about the Captivate node and what they're doing. And then we'll have a very brief overview at the end if you wish to engage with us to help design and deliver your trial, how to go about that. And we'll have hopefully about 20 minutes for Q&A at the end. So I'll get started with introducing ARDT. And those of you who are working in rare disease will know that there are a very large number of rare diseases. So although each one individually is rare, there are still a large number of people who are affected by a rare disease. And unlike many common diseases, 95% of rare diseases have no approved treatment, and as a result, patients with those rare diseases often lack hope of treatment. And as I'll come on to later, traditional approaches to conducting clinical trials, large, well-powered, parallel group randomized controlled trials, aren't really suitable when you have a very limited number of patients to recruit. So the ARDT and Captivate believe that this needs to change, and we need faster, more inclusive trial designs, need more patient-centered research, and ARDT is a collaboration between different parts of the United Kingdom. We believe there's a need for stronger collaboration across the 4 nations of the UK. The ARDT is a LifeArc funded centre, and it's one of 4 of these. And it's a UK-wide programme accelerating rare disease trials. So our aims are to help design and deliver better trials for rare diseases, to help with bridging research and regulatory approval, ensuring that patients with rare diseases are represented and involved in designing, delivering trials. And like I said about the 4 nations approach, that's an important priority as well. And it's a large centre with several different work packages, including several cross-cutting work packages. Today, people here from ARDT are predominantly involved in the work package 3 part, which is focused on trial design and delivery. And this is funding a specialist trial management and statistical team with dedicated staff to accelerate trial setup and to ensure that we can develop trial designs using the most suitable, potentially advanced approaches if they're suitable. We're based within 3 different institutions, so the University of Birmingham and the Cancer Research UK Clinical Trials Unit there. Also the Northern Ireland Clinical Trials Unit and Queen's University Belfast, and Newcastle University's Biostatistics Research Group, where I'm the lead for that, and the Newcastle Clinical Trials Unit. And as a set of institutions, we have a strong track record with successfully delivering clinical trials in rare disease. So we have a good experience and expertise in this area. So for the next 20-ish minutes, I'll be talking about what innovative trial designs are and giving you a few examples of methods that we've used in real trials. And this is an overview, so why we might want to make trials more efficient, and how we might do that, and then how we might use external data to augment clinical trials and make them give better information. And finally, maybe more of a future outlook about how we might embed rare disease trials alongside more common disease trials in order to benefit from that. So, what are the issues with doing rare disease trials? Well, the main issue is pretty self-explanatory. Rare diseases affect fewer people. So if we're doing a trial in a rare disease, there are fewer patients available to take part in trials compared to a more common condition. And therefore, if we're doing the same type of thing, like a large randomized controlled trial, then there's going to be fewer people available. It's going to be more challenging to do that. And in fact, it might be impossible for certain conditions that are too rare. So any trial methodology approaches that can lead to trials needing fewer participants without sacrificing the level of evidence, ideally, that we get from randomized trials, will be of great interest to rare diseases. And some of these also make the trial more attractive to trial participants as well, which will help with recruitment. We obviously need, if a condition is rare, for the trial to be attractive to participants in order to deliver it. And we now have a very wide assortment or a toolkit of different innovative trial design and analysis approaches available. And people within ARDT and Captivate have expertise in many of these types of approaches, not all of them, but we do have a good broad overview in innovative methods as well as specific knowledge on many of them. I think it's helpful to consider, because rare diseases are so different in how frequent they are, so I think the definition is something like 1 in 2,000 patients. A condition that affects 1 in 2,000, there'll still be a relatively large number of patients with that condition, so it might still be feasible to do randomized controlled trials. We still might want to make them as efficient as possible, and any methods that can do that will help make them more feasible to deliver. But then on the other side of the spectrum, there are conditions that affect only tens of people in the UK, for example, and it's going to be much different what we can do in that type of very rare condition. In that case, we maybe need to consider alternatives to randomized trials and to figure out what's the best that we can do with the amount of information that we can get in a trial and with other sources of data as well. So I'm not covering all of these methods, but I thought I would summarize some of the approaches that we could use to make rare disease trials more feasible and efficient to do. So in the case where we can do randomized controlled trials, but we want to make things more efficient to make sure that they are more feasible to do, to get quicker results, and to be able to deliver more with the same amount of resources available, we might want to make the design more efficient, and an example of that would be through adaptive designs. I'll come back to that. We might also want to ensure that we're using the most efficient statistical analysis method, so that we're not throwing away information unnecessarily. I'm going to cover one example of that where we've used an innovative analysis approach to reduce the sample size needed for a trial. And then also, if we can do randomized trials, we ideally want to do trials that are going to answer as many questions as possible. And so not just doing each trial in isolation, but combining what would maybe have been separate trials before into master protocols, as they're called, so we can answer more research questions with the same set of patients that there are to recruit. Then if we turn to very rare disease situations, it is no longer possible to do randomized parallel group trials. We want to consider alternatives. So one is when we have external information that we can use. There are approaches like Bayesian borrowing and synthetic control approaches that we can deploy to get as good quality evidence as we can without a randomized controlled trial. If we're in the setting, maybe a chronic disease, for example, where we can treat participants multiple times, then approaches like crossover trials and N-of-1 trials can allow us to have very efficient evaluation of multiple treatments. So it's still a randomized trial, but it's not a parallel group trial anymore. And also, if we have a rare condition that's associated with a more common condition, and in a way that a drug or treatment might be promising for both of them, perhaps we can embed rare disease trials alongside the more common disease trial and get more information that way. So I'm going to start with adaptive designs, and the idea of an adaptive design is that instead of planning how many patients we need to recruit at the beginning, then recruiting that many and doing an analysis at the end, like this, the top part of the schematic shows. Instead, we'd like to use patient outcome information that we collect during the trial in order to make changes to the trial design, but doing it in a way that we maintain the high quality of the trial and the statistical properties. So doing it in a statistically robust way. And the idea of adaptive designs, which are a very broad class of methods that you can apply in many different situations, they should make things more efficient and mean that we can, on average, use maybe fewer participants for each trial, have shorter trials on average, and also provide advantages for participants in the trial, which might make them more attractive to recruitment. So as an example of an adaptive trial that we in Newcastle are supporting, but it's led in Brisbane, Australia, I'm not actually sure, but this is a rare condition, although it is associated with cystic fibrosis, which is a rare condition. This is quite a complex study called FORMAT, which is looking at treating an infection called Mycobacterium abscus. And yeah, the schematic maybe shows it's quite complex. It's actually split into multiple parts representing different parts of the patient's treatment, starting at the beginning when they have an intensive treatment regimen to try and clear the infection. And at that point in the trial, participants are randomized between different treatment combinations that are available. We start the trial with 3 different treatments that are possible that people are randomized between. But the idea of an adaptive design in this case is we're using something called Bayesian adaptive randomization, that as we go along in the trial and we see patient outcomes on those 3 different treatment arms and future arms that are added, we can change the allocation ratio so that treatments that are doing better on patients so far in the trial will have a higher allocation in the future. That can help with both statistical power, so we can make things more efficient, but it also might be attractive to patients that they're more likely to get a better treatment later on in the trial. So moving on to more efficient trial analyses, I think it's really important to consider when you're designing a trial how to analyze the data and how to do so in the most efficient way possible. A very simple example is if you have a continuous outcome and you have that measured at baseline and a follow-up time, by adjusting for the baseline, you can get a lot more efficiency, and that's a common way to reduce the sample size needed. But in other more complex situations, more sophisticated analysis approaches might be needed. And one example of this, which is actually quite common in certain types of rare disease, is the use of responder endpoints, which combine multiple different pieces of information measuring the impact of a treatment on the patient. We call those different components into one responder outcome. So we take the multiple components and then classify patients as either a treatment response or a non-treatment response. And then typically that is just analysed as a binary outcome, which is then, especially if some of the components are continuous information, it's losing a lot of information, and therefore it's making the trial bigger than it needs to be if we use the more efficient analysis approach. So just to give you an example where we use this approach, well, first of all, just to tell you about the approach. So this is a method that I've been working on with others over a decade now. So we wish to retain the definition of the responder endpoint. So we're interested in the proportion of patients who respond to treatment, but we'd like to analyse it in a more efficient way. That means that we can increase the trial power or alternatively reduce the sample size for the same level of statistical power. And we applied this in a trial for what I'll call a semi-rare condition called primary biliary cholangitis, where we prospectively, at the beginning when we were designing the trial, specified that we would use this analysis method instead of the more traditional analysis that treats the response outcome as binary. In this case, the primary endpoint is the proportion of patients who have normalized liver function 6 months after randomization. And this is formed from 2 different biomarkers of liver damage, so ALP and bilirubin. And to be a responder, a patient's levels of ALP and bilirubin have to be within a certain range. So that's involving dichotomizing continuous information, which is therefore losing a lot of information. And if we can use this alternative approach, we can get higher power and reduce the sample size. So we applied for funding to the NIHR EMI panel, and as you can see, this is from the application. We proposed that we would use this augmented binary approach, as we called it, to analyse the trial as the primary analysis. And we calculated that compared to how many patients we'd have needed if we'd used the traditional approach, which would have been 144. Using this approach, we would need 106. And this is therefore a big reduction in the number, which shortens the required recruitment time and the cost of the trial. So in this case, we reduced the cost of the trial from just over 2 million to 1.5 million, which is quite a large saving. And it's quite nice as a statistician to get like a quantitative impact financially on how much money and time a method could save. And this was funded, and the trial is currently ongoing. Finally, in the area of semi-rare conditions where we can do randomized trials, it's always good to think about, instead of just doing each trial in isolation for a particular clinical area, how might we combine different trials together? And one example of this is with a platform trial approach, where we have in one trial multiple intervention arms that are being evaluated. If we have a control group, they'd be compared to the shared control group, which reduces the sample size a big amount compared to doing separate trials with each one having its own control group. It also generally has an adaptive design, which allows focusing on more promising arms as the trial progresses. And then also another really nice area of efficiency is that we can add in new arms as they become available, instead of running a trial, shutting everything down, and then restarting everything, which for a new research question, which takes a long time, we can add in a new research question to the existing trial. So although platform trials are going to be considerably larger than normal 2-arm randomized controlled trials, they'll be a lot smaller and more efficient than if we were to run separate 2-arm trials to answer each research question that we have. So it's worth considering if it's more a semi-rare condition and there's the prospect for national and international collaboration, whether a platform trial approach might be better than everyone running their own trials. So moving to the situation where it's too rare now, the condition is too rare to actually run a randomized trial. What can we do differently in this case? Well, there are increasing amounts of data that we have from patient outcomes from various sources. So this includes from cohorts and registries, and from routinely collected healthcare, and even from previous trials that have been run. And the idea of these approaches of using external information is that if we have good information on patient outcomes from these sources, we can potentially use this information to augment clinical trials. So instead of doing a randomized trial, we can do a trial where everyone in the trial is treated and we're comparing as best as possible to reduce the bias in a way to untreated participants from other data sources. There's two main methods that we could use, and I'm going to cover an example where we use the synthetic control approach, but Bayesian borrowing is another approach that could be used. But the example of synthetic control approach is actually also from PBC, but quite a different setting. And this was a trial that was done by a company where they had done a randomized trial where they'd randomized just over 200 participants, but they had kept people on treatment or placebo up to 12 months, and then the endpoint was 12-month markers of liver damage as a kind of surrogate outcome for longer term outcomes that were important. And after 12 months, I mean, it would be very difficult to ask people to stay on placebo for more than 12 months. And to make the trial attractive, they offered patients the opportunity to switch to the drug, and many did. So they had, I think, just under 200 patients who were followed up for a median time of 6.5 years, which is a really nice set of data, but it's not randomized anymore, and there's no reliable way to use that data to get an answer about the long-term effectiveness of the drug on the endpoint in this case, which is time until death or liver transplant. And that meant that they explored alternative approaches to get answers about that long-term effectiveness. And there are still two different registries in this area, one called Global PBC, one called UK PBC, and both have a very large number of patients with PBC who did not receive the drug that was looked at in the trial. So we have a source of untreated patients from the registries and a source of treated patients from the trial. And the idea is to use these registries to create what we call synthetic or external control groups to compare to the long-term outcomes from the trial treated participants to get a longer term evaluation of the drug. And I'm going over a lot of detail very quickly there. There is a lot of things to consider in doing this, and a lot of statistical analysis methods that you need to use. If you're interested in that, then this paper here does provide more detail on that. But the final result in this case is that we conducted a weighted Cox regression. So the idea of a weighted approach is that we can weight the treated and untreated participants in a way that tries to create as unbiased a comparison as possible, so that the difference between treated and untreated is not due to factors that differed between the populations other than whether they were treated or not. Now, you can't do that perfectly without a randomized controlled trial, but this is as best that we might be able to do when a randomized controlled trial is not feasible. And the shaded region here showed the results where both analyses from each of the registries showed highly significant long-term benefits of the drug for the long-term outcomes. Now, you might be thinking the numbers here are quite large for rare conditions. Of course, this can be used for smaller numbers as well, but we would need to have bigger effects to be able to see differences. So this is a very promising approach to use in rare conditions where you can't feasibly run a randomized trial, but you can do a trial where everyone is treated and you have a good source of external information to use. My final slide is thinking about how we might embed rare disease trials alongside more common diseases. And this might involve combining some of the approaches I've mentioned, but the idea is if a rare disease shares some mechanisms or symptoms with a more common disease, then we might be able to embed trials of that rare condition alongside the same drug being tested in a more common condition with what we call a basket trial. And that would then allow sharing of information on the treatment's effect between the different conditions. And also, we could go even further. And if we have various different sources of data that can create synthetic control groups, we can then use that information, perhaps by comparing the control group to the synthetic control group for the more common condition to ensure it's giving an accurate answer. And then we might feel a bit more comfortable about making conclusions for the very rare condition where we can't do a randomized trial. So I think that's all from me, apart from mentioning that there's a few papers you might want to look at. These first two are quite short commentary type pieces, where this is a bit longer, and they cover these approaches and some others. So I'm now going to pass over to Victoria. I hope you have control.
I'm going to hope this has worked in our seamless planning of this session. So good afternoon, everyone. For those of you who on the call who I don't know, my name is Victoria Homer Ortori. I'm a senior biostatistician at the University of Birmingham, and I'm going to give a very brief overview about sort of the Captivate node, what Rare Disease Research UK is, and then leave plenty of time for any questions that you might have for either myself or James. So the Rare Disease Research Network is a MRC and NIHR funded program of work consisting of 11 of what they call research nodes. So a research node is any sort of research group or collaboration with a specified aim. So I've put an overview of all 11 nodes that are funded. These were 5-year programs, and we're pretty much about halfway through now. So what you can see is that some of them are more disease specific. They are the ones that are shown in red. For example, there are some about sort of cardiovascular disorders, about Parkinson's syndromes, and then there are a couple that are more sort of cross-cutting, sort of disease agnostic, which include ones about ethical, legal, and social issues in rare conditions, different sort of modalities of treatments, such as nucleic acid therapy, and then the one that I come from and the one that I can represent being about changing clinical practice through innovative trial design. So as I said, we're about halfway through now, and what we have been doing during that time is we've been working with various stakeholders, including trialists, patients and members of the public, industry partners, regulators, other methodologists and scientists, to try and address that question really of how can we do clinical trials better in the rare disease setting so that we can get sort of more robust conclusions in a shorter sort of time period. I'm going to go a little bit into how we're doing this and the methodology projects that we're looking into shortly. But one of the key sort of outtakes and the key sort of outputs from Captivate is this idea of sort of a generation of library of resources. So as well as having the standard academic journal outputs and conference presentations, we are actively developing a library, a freely available library of resources hosted publicly on the university website, which, as well as including references to any papers, also has template documents, case studies, analysis code, and everything that generally tries to make the whole process a little bit easier and more manageable. Our actual research node is focused around the idea of 3 methodology projects. So the first one is looking into whether we can compress clinical trial phases into one. So instead of having a phase 1 trial, a phase 2, and then a phase 3, can we compress all of those so we just do one trial that encompasses all pathways? How does that look in terms of the regulatory approval? How do some of those transition periods look like? And really, this is more of an operational challenge and an operational hurdle, because as those of you on the call who are involved in trials will know, it's generally the logistics that slow these things down. So whether we can streamline some of those processes, as well as obviously working out how we make the most robust conclusions at those different time points to ensure that we are stopping when we're meant to be and carrying on when we are also meant to. Our second project is all around this idea of how can we maximize external information. So we very much picking up on some of the work that James has been leading in terms of synthetic controls and Bayesian borrowing, this idea of looking at different methods for generating priors and how in the rare disease setting we can make sure that these prior assumptions about whether or not people think treatment works aren't too overwhelming and don't sort of totally swamp our trial data. But also this idea of looking at what we've termed, what is sort of widely termed as sort of totality of evidence. So if you're in the rare disease setting, it might be unlikely that you could see benefit in any single one domain because you might just simply not have enough patients. But if you could show a small amount of benefit across lots of different ways in which the disease affects patients, that is potentially enough to say that the treatment is overall has a favourable sort of risk benefit profile. So we're looking at methods by which you can aggregate lots of different domains of a disease into one outcome measure and how that can then be used to make those regulatory decisions, as well as how clinically meaningful they truly are. And our third project is all around investigating sample sizes. So just how small can you go whilst just how small can your sample size be while being able to provide sufficient oversight and sufficient sort of robustness for regulatory decision making and ultimately to actually change clinical practice. So we're talking about sort of the regulatory side of it, as well as the reimbursement side of it, as well as the are the community happy if we say a treatment works off not very many patients. And then one of the ways that we're looking at this is we're sort of looking at these ideas of imprecise probabilities and confidence distributions as sort of a completely different way of thinking about our trial results. And so sort of crucial to all of this is a lot of these interactions with stakeholders that we're doing. So one of the things, the reasons that we're here today is that we have this really close collaboration with the ARDT. So the Captivate research node and the work package 3 of the ARDT, there's a lot of overlap in terms of personnel, and it sort of creates and fosters this really nice sort of cyclical relationship whereby in Captivate we can sort of develop new methods, we can then test them as part of the trials in the ARDT to see what does and what doesn't work well. So then the ARDT benefits from sort of trialing out some of the most novel methods that are out there, but we also then get to learn about what does and doesn't work well and refine the methods as we go through. We're also sort of actively doing a lot of collaboration with the other nodes as part of that rare disease research network. And we've held a series of sort of stakeholder workshops. So we held our first one about 12 months ago, where we brought together a panel of patients, members of the public, to talk sort of more generally around trial design and trial perceptions. We held one earlier this year with trialists and methodologists to think about what are the perspectives on the current methodology in rare diseases, as well as to sort of scope out some of the ideas that we're looking into and whether there was appetite for those. And then our final workshop that we were sort of involved in the running of was held just a couple of weeks ago, that we held with sort of regulators and reimbursers to think about how do we sort of improve and sort of streamline the end-to-end process of therapies development and approval in rare diseases that was very much jointly developed and run between various nodes on rare disease research as well as the ARDT. That was all I was going to say, James, so I will hand back to you to finish us off.
I'll see if I can take control again just for the last couple of slides. Okay, so just a few slides on how to engage with us further if you're interested. So with the ARDT, we're seeking proposals for clinical trials to be run in collaboration with our team and our affiliated trials units that I mentioned earlier. And we're expecting to get quite a lot of requests. So when we do need to start triaging which ones we focus on, we're going to be considering these criteria. So it has to be in rare disease, as far as we can assess it, obviously a credible intervention with plausible potential to change clinical practice. Although we are taking on early phase trials, it doesn't necessarily have to be ones where that changing clinical practice is imminent, and alignment with the priorities of LiveArc and the ARDT. We have developed a collaboration form that's available on our website, which is on the next slide. So it asks for a hopefully relatively low amount of, it's not a huge burden to fill in, I hope. We try to keep it low burden where possible, but it would cover everything that we need to know to consider whether we're going to adopt it or not. And here are the the contact emails. So the ARDT email is this one here, but you might want to contact Captivate as well to think about potential methodology projects. And as Tori says, there's a lot of overlap between the people involved anyway, so we work very closely together. This first one, I believe, is the ARDT website, and this one here is for the MRC network of the 11 different nodes that Tori mentioned. And if you want to directly access our form to fill in, then you can follow this link here. So that's everything from the talk. I think we're going to stop the recording now if we can.